I would like to invite Dr. Manoj. Manoj is a senior resident of Government Medical College, Trivandrum, for the next case presentation. And I would like to invite George Kurian, sir. Sir is a senior consultant nephrologist from Amrita Institute for chairing the next session.
Good afternoon to my respected teachers, seniors and my colleagues. My case presentation is of a 39-year-old male from Kollam. He studied till 10th standard, is working as a fruit vendor. Blood group is B positive and history given by patient and is reliable. He is a live second renal allograft recipient. He now presented to our OPD 1 month back with complaints of bilateral lower limb swelling and frothing of urine for 2 weeks and decrease in urine output for 1 week. History of presenting illness. I would like to start the history from the beginning of his illness. His symptoms started in 2006 at the age of 20 years when he noticed facial puffiness and swelling of both lower limb for 2 weeks duration, which was initially up to the level of the ankles and later progressed up to the knee joint within 2 weeks. It was aggravated on long hours of standing. Initially, he did not seek any medical advice and attributed it to long hours of standing during work. He does not remember about frothing of urine or history of cola-colored urine or hematuria or any decreased urine output at that time. No history of orthopnea, PND, or no history of yellowish discoloration of urine. 6 months later, he was found to have high blood pressure. The recordings he does not remember when he was evaluated for headache and he was started on a single antihypertensive, which he was not compliant to and did not have further checkups also. 1 year later, in 2007, at the age of 21, in view of persistent pedal edema, he was referred to MCH Trivandrum, and on investigation, he was told to have leakage of protein through urine and that he has impaired renal function. He remembers that his creatinine was more than 2 at that time. There was no history of fever, joint pain, skin rash, photosensitivity, seizures, epistaxis or hemoptysis or any claudication history of any claudication pain. No history of obstructive voiding symptoms, recurrent UTI, nephrolithiasis, nocturia or cramps. There was no history of auditory or visual impairment, no history of NSAIDs or other alternate form of medicine. From there, he was advised a renal biopsy and he was not willing at that time and was lost to follow-up for the next 2 years. In 2009, at the age of 23, he presented with dyspnea on exertion, nausea, vomiting, and loss of appetite, and his creatinine values was around 12. He was initiated on hemodialysis through right IJV non-cuffed dialysis catheter and had a residual urine output of around 200 to 300 ml at that time, and a left radiocephalic arteriovena fistula was created at that time. He was initially on 2 per week hemodialysis. He had 2 episodes of hospitalization with breathlessness and high blood pressure after in around 6 months, and with respect to this, he was shifted to 3 per week hemodialysis. There was no history of access dysfunction, catheter-related bloodstream infection, seizures, hypotensive episodes during hemodialysis. There was no history of blood transfusion. He was on weekly erythropoietin and iron injections periodically. He remained on hemodialysis for 9 months. Then he was evaluated for renal transplantation with his mother, aged 55, B positive, with no comorbidities as his donor. Cross-match was negative and he underwent a renal transplant from MCH Trivandrum on March 2020 at the age of 24. He does not give history of any costly injection being used for surgery. He had good urine output on first day, no intraoperative or post-operative complication, and his creatinine values declined steadily. Exact values he doesn't remember. There was no section of hemodialysis or renal biopsy done. He was discharged after 10 days with a creatinine of 1.1. He was discharged on triple immunosuppression, tacrolimus, steroid, and MMF, and other prophylactic drugs. His stents were removed after 2 weeks. After 1 month, he had 1 episode of urinary tract infection. He doesn't recollect the symptoms associated with it, for which he was treated with IV antibiotics. There was no renal impairment at that time. He was on regular follow-up with good drug compliance and had good blood pressure control with a single antihypertensive. 6 months post-transplant, he developed high hemoglobin values, and for that, multiple sections of venous section with around 350 to 400 ml of blood was removed every 1 to 2 monthly, and he was started on a drug tab losartan. His blood pressure was in control, no history of sudden onset of breathlessness, and a scan was done which was found to be normal. He also developed high blood sugars after 1.5 years post-transplant, for which he was initially started on oral hypoglycemic agents, and later insulin was added, after which he had good glycemic control. He had stable graft function for 4 years at around 1.2 to 1.3. In 2004, he developed bipedal edema and proteinuria with worsening renal function, and his creatinine was around 1.9 to 2. No history suggestive of infection, diarrhea, or hematuria at that point. His drug levels were adequate. He underwent an allograft renal biopsy and was told to have changes of IgA-related disease in the biopsy, and that no changes of rejection was noticed, and he was advised to continue with losartan and other drugs without any modification. In 2019, at the age of 33, he was admitted with fever, cough, multiple episodes of loose stools with worsening of renal function to around 5. He was treated with IV medication and decrease in dose of his immunosuppressive drugs. A lower GI scopy was done and was told to be normal. Even though his symptoms improved, renal function was worsening, and so an allograft renal biopsy was done, which had features of rejection, for which dose modification of the already existing drugs were advised. His creatinine remained at around 6 to 6.2. 6 months later, he presented with fluid overload and worsening of renal function following an episode of lower respiratory tract infection, and he was initiated on hemodialysis through right IJV non-cuffed hemodialysis catheter. He had a residual urine output of around 500 ml at that time. His left radiocephalic AV fistula had undergone spontaneous closure. His immunosuppressants were gradually tapered, and he was on low-dose prednisolone. He continued on maintenance hemodialysis for 2 years from 2019 to 21 at 3 per week sections, and left brachiocephalic AV fistula was created. History of blood transfusions twice during this period with the WBC filter, but the timing of transfusion he doesn't remember. Meanwhile, he was evaluated for a second transplant with donor as wife's uncle, paternal uncle actually. 55 years of age, O positive, no comorbidities, and he voluntarily agreed to donate. His wife was not ABO compatible. The cross match was negative, and the second transplant was done from MCH Trivandrum on June 2020 at the age of 34. He was given 3 doses of a costly medicine during surgery and afterwards. Surgery was prolonged. There was increased blood loss and intraoperative hypotension, and he was transfused with 2 units of packed red blood cells with WBC filter intraoperatively. Urine output was less than 1 liter on the first day. 2 sections of hemodialysis was done in the first post-operative week, and the creatinine at the end of 1 week was around 4. Urine output improved to 2 liter by day 10, and he was discharged with a creatinine of 1.7 with a urine output of around 3.5 liter after 15 days. No renal biopsy was done, and he was on triple immunosuppression and prophylactic drugs. A nadir creatinine of 1.3 was reached after 3 months. After 1 year post-transplant in 2022, he was admitted with worsening renal function. A serum creatinine was 2.3. No history of pedal edema, proteinuria, or drug default, or history suggestive of any infection, and TAC level was adequate. Renal allograft biopsy was done and was told to have changes of rejection, and he was treated with 3 doses of IV injection on consecutive days and other drugs adjusted. No history of any costly injection or any history of any special type of dialysis using plasma. His serum creatinine came down to 1.5 after 1 week. His renal function remained around 1.5 to 1.6 for next 3 years without any hospital admissions. He had good diet compliance, adequate drug levels, good blood pressure and glycemic control, and he continued with his daily work. 1 month back, he presented to our OPD with bipedal edema and proteinuria for 2 weeks duration, with decrease in urine output for 1 week with worsening creatinine to 3.3. His TAC level was around 3.2, but there was no history of drug default according to him. No history of fever, cough, diarrhea, or dysuria. He underwent renal biopsy, and post-procedure there was no complication. He was told to have features of rejection, which was managed with increasing the dose of his immunosuppression, and he was advised to take 3 doses of a costly injection every 2 weekly. Currently, 1 dose of it is completed. He was not advised about plasma therapy. Currently, his renal function is improving with serum creatinine of 3.1 and a urine output of around 3 liter with no features of fluid overload. Sir, can I continue with the past history?
You can just summarize the.
He's a 39-year-old male with history of facial puffiness, bipedal edema, hypertension, detected at 20 years, progressed to ESRD over 3 years. He was on maintenance hemodialysis 3 per week for 9 months, underwent live-related ABO-compatible renal transplant with his mother as donor at the age of 24 in 2020. Excellent graft function, creatinine 1.1 at discharge. 1 episode of post-transplant UTA after 1 month. Post-transplant complications of post-transplant erythrocytosis after 6 months, and post-transplant diabetes mellitus after 1.5 years. He had graft dysfunction and proteinuria after 4 years. Biopsy had features of IgA. stable renal function for next 5 years. In 2019, he was admitted with fever, cough, loose stools, and worsening renal function. Biopsy done suggestive of rejection, treated with drug dose modification. But renal function continued to worsen and initiated on maintenance hemodialysis after 6 months. Continued 3 per week hemodialysis for 2 years. Underwent second live unrelated ABO-compatible renal transplant in 2020 at the age of 34 with wife's uncle as donor with induction agent used. Had intraoperative hypotension and increased blood loss. Delayed graft function with 2 sections of hemodialysis in first week. Discharged at 1.7 and an adder creatinine of 1.3 reached after 3 months. 1 year post-transplant, he had history of rejection, treated probably with steroids, which was responsive, stable renal function for 3 years, now with bipedal edema, proteinuria, and worsening renal function, creatinine 3.3 for 2 weeks, low TAC levels, and biopsy suggestive of rejection managed with IV injection, probably IVIG and drug dose modification, now having improving renal function.
Okay. So at this stage, what's your provisional diagnosis? You can enumerate the diagnosis.
The diagnosis is ABO-compatible, live, unrelated second renal transplant recipient with a native kidney disease of chronic glomerulonephritis, probable IgA nephropathy. Now with chronic allograft dysfunction, probable chronic active ABMR with post-transplant diabetes mellitus and systemic hypertension. He had a first transplant, which was an ABO-compatible live-related renal transplant, chronic allograft dysfunction, probable chronic ABMR with IgA nephropathy and post-transplant erythrocytosis at that period.
What about NODAC?
PTDM is there, sir. It is now also he is on insulin.
So we'll come back to the history. What is the what is the native kidney disease you think?
So the native kidney disease, probably it's a chronic glomerulonephritis. He presented with proteinuria, hypertension, and renal failure,
right.
And
Most
mostly IgA nephropathy.
Most common
probably
diagnosis being
IgA nephropathy. But there has been a rapid worsening of IgA nephropathy, which is common in our population.
Okay, so most likely it could be an IgA nephropathy, barring the diagnosis of you have a biopsy proven IgA in the graft.
Yes, sir.
So we'll come back to it. Other than IgA nephropathy, other possibilities?
Yes, sir. I would like to keep FSGS, even though FSGS ending in ESRD at this short span of time is less likely, but it can happen in very severe cases, and he was not on any treatment also. Then third can be, considering his age and all, C3 glomerulonephritis is a possibility.
Okay.
Then the one last, if I should keep, I will keep reflex nephropathy, even though there was no history of UTI in the childhood. Even without UTI and even without any vesico-ureteric reflex, this reflex nephropathy can present at this around 2nd to 3rd decades with hypertension, proteinuria, and renal failure.
Any genetic disease you can think?
Genetic C3 glomerulopathy, then
Other than at what age he was diagnosed to have renal failure?
Actually, there was Alport is a possibility, but there was no history of auditory or any visual impairment for him, and there was no family history also.
No family history. Okay, so most likely it is an IgA which has progressed
rapidly.
ESRD in
Short span of time.
Okay, so the problem is that you don't have a biopsy at the initial presentation.
Yes, sir.
So patient had lost follow-up.
Yes, sir.
Okay. So, and to substantiate, probably the post-transplant you have a biopsy and it is showing IgA nephropathy. What are the probabilities? Whether is it a de novo or is a recurrence of the disease?
Sir, there are many possibilities. One, sometimes the donor kidney would be having a latent IgA, but this patient is having proteinuria and renal failure also. So IgA nephropathy, it can be a de novo as well as a recurrent. Since this patient progressed rapidly, there is also increased chance for recurrence of IgA nephropathy. But usually recurrence of IgA nephropathy occurs after more than 5 years and all.
Clinically, because you may find a biopsy proven, even if you do it immediately, you may find IgA, but to have a graft loss, it may take...
It is less likely to occur, a graft loss to occur with this IgA at this point of time.
Okay. No, so the patient had hypertension in the initial days.
After 6 months of his symptom onset, initially he didn't check for BP actually, hypertension.
Any other evidence of severe hypertension clinically?
Clinically, there was grade 2 hypertensive retinopathy in both eyes. Then there was no bruit and all. BP at the time of examination was within normal limits in both upper limb and lower limb. During this presentation, the previous BP recordings he doesn't know, and he had history of persistent headache, which could may be due to high blood pressure.
Okay. The patient had, what do you think the patient had presented with what type of syndrome, whether it is a nephrotic or what?
Mostly it would have been a nephritic syndrome, sir, actually, because there was hypertension, proteinuria, and renal failure. Even though there was no cola-colored urine or or other hematuria, he doesn't recollect that because it happened in 2006 and 7.
Okay. So you are handicapped with not having a biopsy in the early. So suppose if the patient has undergone a biopsy in the initial time, so what would have been, whether it would have changed the course of the disease?
Sometimes if the patient had a crescentic glomerulonephritis or
so what decides the course of the disease?
Hypertension control, proteinuria, systolic BP, diastolic BP, then EGFR at the time of presentation. Then usually it is if the biopsy has crescents or TMA.
So what is the scoring? What is the scoring?
MESC score, sir.
MESC score. What the MESC score stands for?
Mesangial hypercellularity, endocapillary proliferation, segmental sclerosis, tubular atrophy, and C4 crescents, which was introduced in 2017.
Okay. So what is the importance of having this MES score?
MES score actually, it doesn't help in treatment, but it helps us to in prognostication of the disease.
Prognostication. Unlike when you have an ISNRPS classification SLE. So unlike ISNRPS MES score doesn't give you guidelines regarding the treatment, or it may not, rather prognostication of the disease and the severity. That's important MES score. So according to the MES score, if it is so whether you will be able to predict the disease progression in
actually MES score. Actually, IGA prediction tool is there, which has MES component, but it doesn't have the C component. Actually, it predicts the probability of 5-year occurrence of 50% fall in GFR or ESRD, but it is not very much accurate because some patients, especially in our Indian population, can progress faster to ESRD.
So what are the parameters on which the treatment is based on?
The most important thing, first we'll have to control blood pressure, because IgA can have very high malignant hypertension and all. Then we should control proteinuria, and then if there is any crescentic transformation, we should actively treat at that time, so that the kidney can be preserved with immunosuppression other than not being treated at that time. Then BP control, hypertension control, then avoiding other infections which can precipitate, and other avoiding use of NSAIDs and other nephrotoxic drugs. Okay.
What are the mainstay of treatment in patients with IgA?
The mainstay of treatment IgA, first control of blood pressure, salt restriction, then control of proteinuria, then
control of proteinuria, what all?
ACE inhibitors, ARBs we can use. Then then we can use targeted budesonide is also currently being used, which acts as a Peyer's patches. Then
what is the clinical trial concerning
Nefecon, Nefgard and Nefecon.
Okay. There are two trials.
Steroid stop IgA testing trial.
Stop IgA, that is regarding the steroid initially. Targeted
Nefecon and Nefigard.
Nefigard and
Nefecon.
Okay, Nefecon is actually the trial. Right. So that is regarding the targeted budesonide therapy. That's so. What are the other drug therapies? Other or trials which are
IgA, testing steroids, then
have steroids.
steroids
So
we have.
fine.
Then
Then
Blislimumab, then Blislimumab.
what is protector?
Sparsen,
Yes.
Sparsen in IgA nephropathy.
Then targeting April.
Targeting April, actually we have Bliss inhibitors and April. Then April.
What is the drug? One map.
Abatacept.
Abatacept is right, but
Abatacept, April, yes.
okay, just look up. Okay, so this patient has an probably IgA progressed to ESRD, and patient, as you said, is there any in the first transplant? Is there any high risk factors in this patient?
High risk. In first transplant, actually, the one thing is that he had a rapid progression to ESRD, and his baseline disease is not known.
Fine.
So they, and in a age,
I was just asking you about high immunological risk in this patient.
actually it's a
Is there
mother
any
giving to her son. Anyway, there will be haplomatch will be there.
Okay.
Then there was no history of any sensitizing events like blood transfusion
Fine.
or any other. He's a male, so no pregnancy. Then blood transfusion was not there. First transplant it was, and it is ABO compatible also.
Okay.
So it is low immunological risk. That's
Right. So you, what about the age?
age actually. He's 20 years actually at the time of transplant. A younger recipient and an older donor.
So
it can cause
what do you think that that pair, the older donor and the younger recipient?
older recipient and younger donor. The younger one will be more immunogenic, and there is increased chance for sensitization. Not sensitization. Immunogenic, and he will be, his immune reaction will be more stronger.
Okay. So this patient was in the first transplant. There was no induction.
There was no induction agent. He doesn't give any history of induction agent we use.
And it was and the post-transplant period, it was all
It was uneventful.
uneventful. So it was a low immunological risk. Probably it's though it's a age factor, that is only only factor that is to be a little on the higher side. Okay.
Okay, so one issue this patient had post-transplant was erythrocytosis,
Yes,
right? So can you tell us something about what happened to the hemoglobin trajectory after normal transplant, and then we can discuss post-transplant erythrocytosis.
Actually, before pre-transplant, there was no requirement for any blood transfusion.
No, my question is different. You do a transplant, what happens to hemoglobin after transplant?
After transplant, there is increased erythropoiesis, and there is also increase in IGF-1, IGF binding protein and all. There is.
No, that's all right. Can you tell me, say, at 1 month, how many will have still anemia? At 6 months, how many will have anemia? When do you expect the hemoglobin to recover? You understood the question, no? I'm not asking about mechanism of erythrocytosis. Normal transplant, patient didn't take is not developing erythrocytosis. When do most of them will be anemic?
Initially, they will
what
be
happens to hemoglobin after transplant in a normal person?
Initially, hemoglobin level will be low, secondary to surgery and all, then stress and all.
After 1 month?
that, after 2 months, it will slightly increase. And
How many? What proportion will be anemic at 2 months?
At 2 months, 30, 1/3, less than 1/3. Correct, exact.
Okay, we can go and check that. Okay, we should know because most of it will recover, right?
Yes.
Okay, all right. So, who develops? What all risk factor did this patient have for erythrocytosis?
One, he had a male sex. Then there was no requirement of blood transfusion pre-transplant. Then he had a good graft function. Good graft function
So,
and
what do you mean by he didn't require erythropoietin also? What is important?
No, he used erythropoietin actually.
Okay, no. So what do you mean is lack of blood transfusion a risk factor, or what is the risk factor?
No, high hemoglobin pre-transplant is a risk factor.
Lack of anemia indicating residual erythropoietin production is the risk factor, right? So it's not lack of transfusion. Patient may be getting ESA therapy, right? All right, very good. Male recipient,
Then,
lack of significant anemia pre-transplant.
Hypertension, smoking, then residual renal function, then renal cell carcinoma, transplant renal artery stenosis. These all can predispose to post-transplant erythrocytosis. And and
Okay,
smoking.
All right. So when will you say somebody has post-transplant erythrocytosis?
Usually it occurs 8 to 24 months post-transplant, and if he is having persistently elevated hemoglobin, and usually the KDO tells us that hemoglobin more than 17 and hematocrit more than 51 for more than six months, in the absence of erythrocytosis, leukocytosis, and other causes of increased erythropoiesis.
All right. And how will you treat?
Actually, the first line of treatment, whether we should rule out the secondary causes first, whether there is renal cell carcinoma. It can occur in the native kidneys, and then if there is transplant renal artery stenosis, then we should correct it by, it is due to high activation of RAS system. So we can use ACE inhibitors or ARBs. Then if for symptomatic benefit, we can use venesection.
When will you do venesection?
When hemoglobin, actually the cutoff is that when the patient develops any symptoms like chest tightness, dizziness, persistent headache, we can do. Otherwise, if there is hemoglobin more than 17 and hematocrit, usually, and associated symptoms are there, we usually go for venesection around 350 to 500 ml.
Fine. Okay. So this patient had PTDM. So is it possible you are going to do transplant for someone? Is it possible to make an assessment? Okay, what is the risk of PTDM? Or how do you go about that if you want to do?
Whether the patient had diabetes before, sometimes patient may not be diagnosed beforehand because they were on dialysis and insulin. Metabolism was...
if somebody was diabetic, then you expect diabetes to be there, right? My question is somebody who is not having diabetes at baseline, is it possible to predict?
Yes, sir. Age more than 40, high BMI, then with that genetic polymorphism in some patients, then if a cadaver
Which
transplant...
polymorphism? What do you mean by genetic polymorphism?
HNF4 alpha, then ACE polymorphism.
Okay, all right, fine, go ahead.
Age more than 40, high BMI, then extent of immunosuppression. If it is an ABO incompatible or cadaveric transplant, there would be need for higher dose of immunosuppression, and these immunosuppressive drugs can cause PTDM in the sense that...
what are, before transplant you are predicting, so one patient is having
age
high
more
BMI,
than
age, BMI.
then age, BMI,
You understand, no, patient, you counsel the patient before transplant saying that you may have diabetes after transplant. You do that, no?
Yes, sir.
Most of them will be.
Yes, sir.
So if the patient asks, am I likely to develop PTDM, what will you tell?
Glucose tolerance.
Okay, all right, very good. If you find impaired glucose tolerance, anything else?
Impaired glucose tolerance. Then family history of diabetes is
very good.
important.
If it is a lady, is some history which will help.
Sir?
If suppose it is a lady who is there.
GDM, history of GDM during pregnancy.
Okay, very good. Any infection, history of any?
Hepatitis, liver infections, hepatitis C infections, hepatitis.
So you know, right? So there are predictors.
Yes.
Okay, all right, fine. This patient had graft failure due to what reason? First graft failed, right? What do you think
Sir,
is the reason?
mostly the cause for graft failure would be he had at 2019 he had a history of fever, cough, loose stools, which was treated with IV antibiotics, but renal function didn't improve. At that time, his immunosuppression was decreased. After that, when a repeat biopsy showed changes of rejection, mostly that would have been a chronic antibody-mediated rejection. The predisposing factors was there was a decrease in immunosuppression, and the drug compliance. Even though he tells he's complained, the most common cause, one of the most important cause is non-adherence, and at that time, because of
this patient apparently had this problem in 2004, right?
no, sir. His symptoms started from 2006. He had creatinine of 1.9.
Okay.
That
No.
was IgA actually. Sir.
Even before that, yeah, it was IgA.
Yes, sir, IgA. With features of IgA, but it is not confirmed whether it is IgA nephropathy. But since he had proteinuria and pedal edema also.
No,
That
so
was
that's why I'm asking. On one hand, you are telling biopsy showed IgA nephropathy, he had edema, frothing, but you seems to think that the graft failure was from chronic antibody-mediated rejection.
Sir, an IgA nephropathy to progress faster from 2014
Can you tell us
to
something about recurrent IgA?
recurrent IgA, actually clinical recurrence is in 30 to 40%.
Are you aware of any studies, data from any studies?
Means one CMC, one Grace IgA study is there.
What is TANGO study? TANGO. TANGO.
Tango studies, I don't know, sir.
Audience, somebody wants to? This is not exam. No? TANGO study. Okay, you can go and check that. Okay, it's a multi-centric international. Came sometime back, 2019. It has data on multiple things. So it had IgA also. You can go and check that. What are the risk factors? It was an observation study only, but then very nice, I would say, one nice study. It has data on FSGS, membranous nephropathy, and as well as IgA. So can you tell us what are the risk factors for recurrent IgA? When does it recur? What is the expected time?
Usually 30 to 40% have clinical recurrence, but mostly bigger percentage, 70 to 80% will have histological recurrence, but graft failure due to IgA is less common.
Can we go one by one? What are the risk factors for recurrence?
First, good renal. First one is rapid progression of the native kidney disease and crescentric transformation, presence of crescents in the native kidney biopsy, if it was biopsied. And the rapid progression is the most important thing. Then a good renal function post-transplant.
Presence of crescents has been shown to be a risk factor for recurrence.
Means crescents usually it will be having a rapid progression and rapid progression.
All right, no, let's not guess. Okay, all right, fine. So rapid progression, basic disease,
progression.
all right. What else?
Then a smaller age at the time of
Younger age
IgA,
at the time of
usually
transplant.
males, and good graft function post-transplant. And early withdrawal of steroids is also in some.
What about late withdrawal?
Late withdrawal? Actually, early withdrawal is associated with increased chance, but it was
Okay,
not
all right.
statistically
What else?
significant.
It is steroid avoidance of any form. It may be early.
Steroid
Most of you will, if you want to withdraw, you will withdraw early. So, but it is avoiding glucocorticoids, right? So, what else? You are telling a rapid progression, more severe disease, younger age of kidney failure or younger age of transplant?
Younger age of kidney failure. Initial time and
All
younger
right,
age of
okay.
transplant also.
All right. And you are telling good graft function is a risk factor for recurrence.
Means good graft function means he will have a very big time, so there is increased chance for recurrent disease to occur. If it was early graft.
Okay, not really. All right. What else? Anything else? Anything to do with the donor?
In actually live related donor, actually sometimes IgA can run in families. So
Okay. All
then
right. So that is the reason the IgA occurs if it is a living related donor. Suppose the maternal family had IgA and the father donated?
less chance.
Less chance. Really?
Yes,
Anything to do with HLA?
HLA it is there, sir. Actually, HLA B7.
All right, so you can go and check.
HLA A4
fine.
and
It's
B7.
all right, okay, fine. So you can go and check. Right, there are well-defined risk factors. This TANGO study also showed some of the I would say documented risk factors. And can you do something to prevent recurrence? You know that the basic disease was IgA, proven on biopsy. He had relatively rapid progression, not responsive to treatment. He is young, and the mother is donating. HLA is, let's say, it is zero mismatch.
First, we can look at an implantation biopsy of the mother to see whether, if she is the donor, to see whether she has IgA deposition.
Okay, so having IgA in the donor kidney is a risk factor for recurrence. What happens? Suppose the donor kidney, let us say you got a diseased donor kidney, you did a pre-implantation biopsy, but the biopsy report came later, you went ahead with the transplant, but the biopsy they said that there was IgA deposition in the donor kidney. What to do now?
Sometimes it may be just histological IgA, sir. Latent IgA can be seen in around 20 to 30%. That actually...
No, that is in the donor kidney. Now what will happen to the recipient? Donor is brain dead. No, he is dead now. Okay. We are not worried. Now that kidney was given to this person who had kidney failure. What do you expect will happen to him?
There is chance for
It usually resolves. Okay, the IgA resolves. If you look at literature, it is supposed to be a risk factor for rejection. There is a higher rejection rate, nobody knows why, but there are documented studies documenting that IgA usually disappears. Right, so IgA deposition in the donor kidney is not a contraindication to transplant. Right, okay, so what else? My question was, do you know that there is a person who is at risk of IgA? Can we do something to prevent recurrence or reduce chance of recurrence? All right, so now you have somebody you can go and check that, okay. Somebody is post-transplant. What is the time usually they will have clinical recurrence, average time?
Around more than 5 years, sir, anyway, around 8 to 10 years.
All right, Tanko study, I think it was less than, I think it was between 3 to 4 years, 3.5, something like that, but okay. All right, so now somebody has biopsy documented, proteinuria is there, BP has gone up. How to treat that patient?
First, we can treat with ACE inhibitors or ARBs.
All right.
And then control of BP.
All right, very good.
Proteinuria control. Then
anything specific to transplant, or is it just like
avoid steroid withdrawal?
So you should not try to minimize or avoid, give the standard treatment at least. All right, so somebody has a recurrence, and this patient had 1.9, and then he had some rejection. You were telling chronic antibody-mediated rejection. The creatinine was high. Is it possible to objectively predict when the patient will develop graft failure? Let us say a patient had transplant, and now the creatinine is say 2, 1 year after transplant. Patient is asking how long will the graft survive. Is there any way to predict how long the graft will survive? Objective way, I'm telling.
Graft half-life. The graft half-life concept.
Any objective way is there? Validated. What is iBox?
iBox is actually by using artificial intelligence. The French.
No, there's no artificial intelligence involved.
Developed by French actually. iBox is
which French group?
French group. iBox.
There is one well-known French group. Which group is that? Paris Transplantation Group, right? What is iBox? What is
intelligence.
Not intelligence. It has nothing to do with AI.
iBox.
Integrative box, right? What are the components? There is no AI there. I'm not aware of any AI being there. Because I think it's important to know, because this is well-validated, well-documented method, objective method. It is supposed to be integrated into EMRs. Of course, it is not validated in Indians, but death-censored graft survival. Death is not counted. Okay, so it has functional markers, it has histological markers, it has band scoring going into it. So there is a validated, I would say, I'm repeating the point, validated, because it is validated in a big multiple transplant studies also, right? So it's possible to predict to some extent, right?
He goes for a second transplant. What are the immunological evaluation that you have done for that?
This patient actually only CDC was done. Ideally, HLA typing should have been done because he's an
So what are the sensitizing events?
He had a history. He passed. The most important thing is previous transplant. Then he had a history of two PRBC transfusions. This was an unrelated transplant. From
so the transfused blood was whether it was a normal PRBC or
using WBC filter, sir.
Filter. Okay.
Then unrelated transplant. Then another thing is that during transplant there was increased blood loss and further 2 units of transfusion was there.
So it's only CDC was done.
Only CDC was.
So what you would have done more in this patient to evaluate the immunological?
Flow is actually HLA typing. Then screening antibody test can be done, and if any of this positive, we can do a SAB testing on Luminex platform, and we can know the titer whether if there is any significant DSA is there. And if the DSA is more than 15,000 is unacceptable, and less than 1,000 to 2,000 is
What is this 15,000? What is the units?
MFI, sir, mean fluorescent intensity.
Right.
And this, ideally, in our protocol is that we will do screening, first screening, then if any one of them comes positive, we will do the SAB of that, either SAB 1 class or SAB class 2, then CDC and flow is also being done.
Flow is also
being done.
right. Okay. So this patient has under what induction he has received?
He received actually, gives
What do you think? What do you think the
mostly ATG and we also use ATLG also, sir.
ATLG? What he has received? Whether
actually
couldn't,
correctly, mostly ATG or ATLG, sir. If it was it was anyway
so
not.
it was written three costly injections. That's
Yes,
what you.
Can be ATLG also. Usually in our protocol we give 3 doses.
Whatever anti-lymphocyte preparation. So what do you think? Giving ATLG or what is the other induction agent usually used?
Sir, in low risk we can use basiliximab, which is an IL-2 receptor antagonist. Actually, 2 doses are given, 20 mg on day 0 and day 4. Then other thing is alemtuzumab. It is not used nowadays. It is a far more completely depleting agent. Then ATG is used and ATLG is used. ATG, rabbit ATG and equine ATG is there. We use rabbit ATG. Then for low risk we give around 3 mg per kg dose, and for high risk 6 mg per kg. And ATLG, the recommendation is 7.5 to 9, but we give 4.5 6 mg per kg.
Okay. So what is the maintenance immunosuppression given?
Maintenance immunosuppression for this patient was tacrolimus, mycophenolate.
The patient had a delayed graft function, is it?
Yes, sir.
Post-transplant, he received...
In second transplant, he received, he had delayed graft function.
Okay, right. So, what is the immunosuppression that you have given?
We gave tacrolimus, mycophenolate, and steroids.
Okay. What is the advantage of giving ATG in such scenario when there is a delayed graft function?
We can do the maintenance drugs can be introduced lately if we use ATG. But actually ATLG in that graft function in the long term, it doesn't have much important studies tell that. But the use is that we can, early time acute rejection will be reduced, and we can also reduce the dose of maintenance immunosuppression and cause delayed.
Especially in the immediate post-transplant period when there is a delayed graft function, probably due to ATN. When you give a CNI, the DGF is delayed,
yes,
further delayed. Okay. So this was an unrelated transplant. So with all sensitizing events and high risk immunological transplant. So patient was given probably ATG, and then there was a delayed graft function. Patient, the nadir creatinine was 1.3.
Yes, sir.
Okay. And then a patient developed a diarrhea. Is it?
Sir, it was in the first transplant, sir, diarrhea.
Okay, right. What are the cause of diarrhea in a post-transplantation?
First, diarrhea, it can be infective, non-infective. Non-infective immunosuppressive drugs and other drugs which the patient takes. Immunosuppressive drugs, example, mycophenolate and tacrolimus, and non-immunosuppressive drugs, whether any other antibiotics, diuretics. And in the immediate post-op, if the patient was on many antibiotics, Clostridium difficile can occur. Then the post-transplant, the most important infections are CMV infection, and especially in the first 1 to 6 months. Then they can have adenovirus, norovirus. Then norovirus is now increasingly recognized. Then Clostridium difficile. And then rotavirus, then infection, cryptococcosis, cryptosporidium, microsporidium, and then adenovirus, sapovirus.
Okay, then other non-infective complications?
Non-infective cause of diarrhea, immunosuppressants. Then that additional, we give that phosphate agents and all, sodium phosphate granules, they can cause diarrhea. Then steroid can also cause GI irritability. Then
you said drugs, infections.
Sir?
You said drugs, infections, and then
drugs, infections. food. Proper.
No, you said about all drugs which can cause diarrhea, infections you said, then anything else?
Yes, sir. Sometimes GI malignancies can happen.
Yeah,
Actually,
what
GI malignancies then,
most, especially in post-transplant scenario?
actually, colonic malignancy, CA colon can happen. Then PTLD, it can present with malabsorption and all due to EBV.
So PTLD is one of the important
Yes, sir.
causes of diarrhea. When it is not, then
Then
infective, one important infective complication you have missed.
CMV.
What about tuberculosis?
Yes, tuberculosis, GI tuberculosis.
Okay. Some patient, no, you suspect CMV, but the CMV PCR is negative. Could it be still CMV?
Yes, sir. In invasive tissue disease like in GIT and in retinitis, sometimes PCR can be negative. So we should go for a GI upper endoscopy as well as lower endoscopy.
Even CNS, that is it could be compartmentalized. CMV may not be in the bloodstream. So in such cases, especially in GI, you have to have a tissue diagnosis so to make whether it is to rule out CMV disease. Okay. CMV, what are the tests that you do to
CMV, nucleic acid amplification test, CMV PCR, then CMV PCR, P63 antigen, then
so in the pre-transplant scenario, what we will do?
IgG and IgM for donor and recipient typing we use, IgG typing. To know whether the risk, whether it is D plus R minus, D minus R minus, D plus R plus.
Not the PCR.
No, sir, we
Why?
use IgG. PCR,
in
sir,
the
actually,
post-transplant scenario, you use PCR for
because he was
diet.
not, post-transplant he will get immunosuppressed and there is increased chance for getting CMV. And
so this is you are looking at remote infections in the past.
Yes.
The pre-transplant, just to categorize, whether it is a D plus or D minus R plus. So you will you need to know the
immunosuppressant prophylactic drugs, how much duration we should give, and for D plus R minus we should anyway give for 6 months. Our protocol is we give for 6 months. In D minus R minus we can get away with not giving immunosuppression. It's not giving prophylaxis also.
Okay. About EBV, do you screen for EBV?
Sir, actually ideally we should screen for EBV, sir, but we are not screening, sir. We should screen for EBV.
Why don't we do screen for EBV?
Actually, if EBV, the one thing is first to know the risk of PTLD. If a patient with EBV negative receives EBV positive, there is increased chance for...
What is the percentage of EBV positivity in the general population?
More than 80 to 85% actually.
Is it?
85. EBV positive, zero positivity, 80.
Okay, just check again what is the percentage and why you don't, you are not doing it in the pre-transplant. We are not screening. In CMV we are screening.
Yes.
Screening is not a difficult thing to do for a EBV. Okay, right.
This patient apparently was doing well for a long time after the second transplant, and looks like the creatinine just like that went to 3.3, right? It was around 1.3 like that.
One episode of rejection was there, sir, earlier also, 1.3. After 1 year post-transplant, he had a likely cellular rejection, like it was treated with 3 doses of IV
so
injections.
that was in 22, and after that he was doing well
Yes.
for next couple of...
Yes.
Suppose somebody develops graft dysfunction like that, he's asymptomatic, the creatinine has started going up, say 2 years after transplant. What are the possibilities?
Sir, another cause for a creeping creatinine is BKV. We should always...
No, what are the, not another, I am telling, suppose not this patient, any patient, transplanted, everything was going well, and after say 2 or 3 years, the creatinine has started going up.
Sir, one rejection, whether if he was not adherent to drug or then...
Okay, so acute rejection.
Acute rejection is a
Alright.
possibility. Or sometimes slowly the chronicity will be there. De novo antibodies production will be there. And if...
No, so that is not a rejection?
Yes, it comes rejection.
All
Then
right, okay.
drug toxicities can happen, sir.
Okay.
Tacrolimus especially. Then when if
So
there was
CNI toxicity, one is immunological, means
Yes.
rejection,
rejection.
right, and drug toxicity.
Then infections in our setting, most common is infections.
Which infection?
BKV actually can present as a creeping creatinine with good urine output but worsening renal function.
Okay, but when do BKV usually present?
Usually in the initial time when the immunosuppression is at its maximum.
What is the usual time?
First, in 1 to 6 months and up to 1 year, there is increased chance.
Okay, so this patient is between 2 to 3 years,
Yes.
no? BKV is seen during that time, or?
It can be seen at any time, sir.
All right,
Actually.
so it can be, but less frequent.
Less.
Okay, agreed. What
Then
else?
sometimes CMV infection can be less symptomatic also, can present.
Okay, patient, the only problem here is graft dysfunction. There is no other symptom. How likely is it is CMV nephropathy?
CMV less likely in this.
Okay, all right. Anything else? So you are telling rejection.
Yes.
Drug default means acute rejection, chronic antibody mediated rejection,
Chronic antibody.
CNI toxicity,
Yes.
BKV.
Yes.
Can it be anything else? No, what about this patient?
Recurrence actually.
Okay,
Recurrence of the glomerular disease or any de novo glomerular disease. Can
Okay,
happen.
very good. Recurrent or de novo disease, very good.
Then worsening of hypertension and.
All right, so suppose it is biopsy, you did biopsy and you found it is chronic antibody mediated rejection. How should we go about treating that?
Actually, this patient has a chronic antibody mediated rejection more than 1 year, so there is not much evidence.
Let us say it is newly diagnosed. You did a biopsy and you found chronic antibody mediated rejection now.
Okay.
How should we treat?
Chronic, if it is chronic ABMR, we can increase the already existing drugs, because if a TAC is, we can increase the TAC level by around 25% of the existing dose, and if he was on a steroid
You will
free
go by
regimen,
TAC dose or by TAC level?
TAC level.
Okay. So
TAC
you
level.
you like to increase the C0 by 25%.
Yes.
Suppose it was already 6.
We can keep it around 7, sir. Actually. 7. And
Alright.
if he was on
Suppose it was 7.
sir, after that, we
So
can
anyway you
improve
will
other
increase.
immunosuppressions also.
No, my point is, anyway you will increase.
Yes, sir.
Is that what you mean?
No, if it is not in the therapeutic range.
Okay. So the underlying principle is that by for some reason it is possible that long after transplant patient may be a little lower than what is recommended or whatever, right?
Yes,
So
sir.
you will optimize it.
Yes, sir.
Nobody recommends increasing blindly, right?
Yes,
If
sir.
the TAC level is okay, MMF is up, you can check the level, or by weight the dose is okay, then you are not supposed to increase it. Why?
A toxicity of the drug will happen.
Because there is not going to be any benefit and you are
Chronicity
likely
of-
to end up with complications. So answer will be optimize. In case it
Optimize.
was low, you will optimize. All right. Anything else?
Optimization of the already existing drugs, and if he was on a steroid withdrawal or steroid free, we can add steroid.
All right.
Then in chronic active ABMR, we can also give IVIG, but Plex is not advised in ABMR occurring more than 1 year post-transplant, because mostly it will be due to
What is useful? So optimizing immunosuppression.
IVIG is also useful, sir. IVIG.
How much will you give? What
3
dose will you
doses,
give?
sir. 200 mg per kg, 3 doses, 2 weeks apart.
Okay. And?
Then
That's it?
rituximab, in Borti,
No, no,
Borti
IVIG, that's it. You will give and then the graft function is likely to improve, or what is it like?
sir, if it is chronic active ABMR, there may be mild improvement, sir.
No, do you give just one dose or you will give
No,
repeated doses?
3 doses, sir. 3 doses.
Okay, 3
3
doses at what
2
interval?
weeks interval. 2 weeks.
Okay, and then you will stop.
Yes.
Okay, all right. Anything else?
Sir,
What are the other drugs tried?
We can actually try, bortezomib is actually tried, Borteject trial, even though it was a negative trial, 1, 4, 8, 11, and a second course can also be given on day 1, 4, day
What
1.
about rituximab?
Rituximab when there is micro invasion and when there is high titer DSA, but at this stage, if it is more
Okay,
of
all right. So
chronicity,
there is very little other than optimizing immunosuppression.
IVIG.
As of now, evidence is not there to support other things. You may try in some selected patients. Okay. You did say that, no, that was, I found it interesting that the graft function showed some improvement.
Yes, sir.
And then you said creatinine 3.2 and 3.1.
Yes,
So is that a improvement or?
Not, sir, not.
When will you say it has
When if
improved?
in a ABM, if it is a T cell mediated rejection, it should come to baseline less than 10% within 5 days, and if it is ABMR, it should come down to less than 20% of the baseline after treatment. It is
Okay,
not.
but so that is for acute rejection. No, here you are thinking about chronic rejection. So When will you say there is an improvement of graft function?
When it,
Anyway, it cannot be 0.1,
yes.
right? Why it cannot be 0.1? Why can't it be an improvement?
Sir,
Why can't it be an improvement?
it is not much changes there, sir, actually.
Okay, so what is the expected lab variation in creatinine assay? Suppose you send a creatinine, today it is 1.2, next day it is 1.3. Is it possible that it is
Yes,
a lab
sir.
variation?
It can be lab variation.
Suppose
sir.
it is 1.5.
It depends upon the technique, the one who
No, you will
technician
use,
also.
what technique will you use?
Creatinine, Japhase,
Japhase or modified Japhase or
modified Japhase.
anything else? How do you standardize creatinine assays? IDMS you have heard, I am sure. What is IDMS? Okay, so you are supposed to use IDMS traceable technique. So in that, suppose you use the standardized, validated technique, how much variation is considered normal?
Plus or minus 0.2, sir.
Yeah, guesswork only, but you are correct. It's 0.2, right? All right. So my point is, to say it has improved, we cannot say it casually. So you said something about 3 doses of thymoglobulin. So what is the recommended dose of thymoglobulin? How do you decide whether you have given enough dose? Suppose you don't have thymoglobulin, you have to use ATLG. How much to use?
Sir, actually, first whether he's a low immunological risk or high immunological risk.
No, you have decided to give. Now the
Then,
question is how much to give.
The peripheral CD3 count we can look, sir, actually.
Baseline you will check, or how do you? No, there's a patient in your assessment, patient is high risk. You decided to give thymoglobulin. Now how much to give?
High risk 6 mg per kg, but if we also should monitor the total count and platelet also. Then the CD3 count less than 50.
Why do you want to monitor the total count?
Actually, it can cause cytopenias also. So if total count less than 2,000 and platelet less than 75,000, we should hold thymoglobulin till it improves. And if it is between 2,000 to 3,000 and platelet between 75 to 1 lakh, we can give it half dose. And
what is the reason the counts will go down? Because in leukopenia is a problem, right?
Yes, it causes profound suppression of T cells, B cells. Then,
okay. How much of suppression?
The suppression actually,
you can go and check that. Okay, this
lasts
is
for 6
this
months.
Is something which I don't know. People, if you are using thymoglobulin, what you find is depletion of lymphocytes. There is no dramatic impact on the absolute neutrophil count as such. So you have to apply your because we have used, and let me not go into that. Leukopenia patients we have used thymoglobulin. So, but anyway, how much to suppose leukopenia is not there? What is the correct dose to use?
Sir, 1.5 mg per kg, 3 to 4 doses we usually give, sir.
Okay, and how do you decide whether dose is sufficient?
The renal function is improving. Then there
It
is
is based on you already told the answer. CD3 count.
CD3
you can
count
check,
less
right?
than 50 actually.
Okay, all right. If you are using ATLG, how much will you use?
ATLG 6 mg per kg, sir. Usually
Same dose.
6 mg per kg. We usually three doses we give. Each dose 100 mg actually.
No, what is the suppose you said you will give 6 milligram per kg of thymoglobulin.
For ATLG actually the recommended dose for high risk is 7.5 to 9 mg per kg.
Now what is the conversion? Suppose you are in the habit of using 3 milligram per kg of thymoglobulin, and now today you are using ATLG. How much will
4.5.
3 to 4 times the dose. 3 to 4 times the dose is the conversion. If you look at the biological equivalent dose, suppose you are giving 3 milligram of thymoglobulin, the equivalent dose is 3 to 4 times. That will be how much? 9 to 12 milligrams. So approximately 10 milligram, right? What are the problems with using thymoglobulin?
Sir, thymoglobulin causes profound T cell and B cell depletion, so there is increased chance for immunosuppression, especially with introduction of maintenance immunosuppression. Then
there are short term, there are long term. What are the short term problems?
A short term problem, infections,
can you
cytopenias.
Can you tell me before that, how will you administer thymoglobulin?
The thymoglobulin is administered through a central line catheter because peripheral can cause phlebitis, and it is administered over 4 to 7 hours. Initial first dose we will give it over 6 hours with pre-medication of steroid and paracetamol with Avil.
All right.
And
Okay. Fine. So
we
what are the adverse effects?
infusion-related syndromes are there. So it can cause infection-related symptoms, then phlebitis, then hypotension, drug allergy, then ATG, thymoglobulin. There will be increased reactivation of the certain diseases.
Which all diseases?
Thymoglobulin can viral infections especially, sir.
Okay, like
hepatitis there can.
hepatitis C.
Then hepatitis C.
Anything else?
Increased risk for CMV and PKV.
All right. Anything else?
Hepatitis, CMV.
So you are telling increased chance of infections is there, long
Yes.
viral infections. All right. Anything else? Other than infections, any other concern?
Cytopenias.
Okay.
Malignancies increase.
Which malignancy?
EBV related PTLDs and all.
Okay, PTL.
Hematological malignancies.
Okay, all right.
So we have 10 more minutes to wind up the session.
So this you have ATG, then if you, what is the advantage of using alemtuzumab? We are not using in our usual day-to-day clinical practice.
It's an oral drug, sir, so ease of administration.
Oral?
30 mg.
Is it oral? No, ease of administration. That is the one which. Okay, it's not oral. So 30 mg, that is right, but the 30 mg for the probably just like ATG, when you say in high risk 6 mg per kg, where use most of the 15 to 80 milligram will suffice if you are using alemtuzumab. Very easy of administration, because just like infusion related complication that you can encounter with the ATG, that is not there with the alemtuzumab. What is profound T and B? That's
alemtuzumab causes profound cytopenias, both T and B lymphocytes.
Okay, so that is.
Then T regulatory cells also decreases.
Right.
Actually.
And you have maintenance immunosuppression. Which regime has found to be superior in clinical trials?
The standard tacrolimus, mycophenolate and steroid is.
Which is the trial?
In Elite Symphony style, actually the better one was a slightly better outcome with tacrolimus, MMF, steroids, and
So
induction with tacrolimus.
What were the four arms of the Symphony trial?
4 arms. First one was cyclosporin, MMF, and steroid. Then the next 3 had daclizumab as an injection agent. First one used low dose tac. Second one used low dose sirolimus. Third one used and low dose cyclosporin along with steroid and MMF. Of it, the better one was low dose tac, MMF, and steroid. And the daclizumab was used as injection for last 3 papers.
Cyclosporin, there were 2 arms.
Cyclosporin, full standard dose and low dose was used.
Okay. So with the belatacept, what was the drug compared?
Belatacept and 2 trials are there. Benefit and Benefit X trial.
Okay.
Actually, belatacept is it was initially introduced so that it can improve compliance, because only a single month infusion was. Monthly infusion was required. It was compared with cyclosporin.
Cyclosporin, right. It was not with the tacrolimus.
Cyclosporin.
Okay. So, this patient had almost, it's probably a failing graft.
Yes, sir.
Right. If he requires another transplant, so what all things you anticipate, and
Sir, first,
what are the problems that can occur in that?
Now the tapering of immunosuppression, actually for a failing graft, if we are expecting a transplant within 1 year and the patient is not having any infection, the patient is not frail, we can we can reduce the antimetabolite by 50%, but we can continue CNIs and steroids. But if the patient is severe, if it is, he's expecting second transplant, no sir?
It's a third transplant.
Third transplant.
No,
Then
the
actually
two
we should
transplants
make
already-
anatomical issues, we should make space for the next
one is
transplant.
anatomical, right? So, what all things you will,
Sir, actually, now he have,
where you will place the kidney?
sir, we can remove the native kidney actually,
Native
sir.
kidney. Okay. So, do you remove the native kidneys in other for a second transplant?
No, sir, unless patient is having recurrent infections and that malignancy risk, RCC is there, or secondary hypertension, severe hypertension not controlled, we can remove. Otherwise, large AD.
What are the problems related to removal of the graft kidney?
Actually, graft kidney, the sponge hypothesis is that the graft kidney will act as a sponge and it will absorb all the DSAs. So, especially next transplant will be more sensitizing. So, this will act as a sponge and can hold on the DSAs.
Okay.
So, it is actually, immunologically, it is supportive actually.
Right. So, that's okay. Second, surgically, what is the?
Surgically, sir, the place for anastomosis, then the transplant space will not be there actually. Already 2 kidneys are there. So, better we should remove the native kidney and keep the third kidney there.
Okay. So, and one more thing, when the patient is back on dialysis, but may have a transplant in future, So, in such a case, whether you will withdraw immunosuppression or?
No, sir. If it is, if we anticipate the next transplant to within less than 1 year, we will keep TAC or at the most reduce it to 50%, and we can reduce MMF also, and steroid it will be kept in a low dose. But if it is anticipated more than one and otherwise if we completely stop, there is increased chance for graft intolerance syndrome also.
Okay. Right.
Tell us something about how do you measure TAC levels?
TAC levels actually, it's in our setting it is measured with chemiluminescence microparticle assay. Other tests are the most best one is high performance liquid chromatography, then fluorescent assays there, then 4 assays are there, sir. 3 only.
Okay, all right. So, what is the all are equal, or what is the, suppose you are doing immunoassay and some patient comes, you send to another lab and they do it by LCMS, will there be any difference, or should you be interpreting it different?
Sir, actually there will be difference, sir. Actually.
Okay. Why there will be a difference, and what sort of a difference do you expect? You drew a sample, one you sent to for say chemiluminescence assay, for example, and another same sample was sent to LCMS assay. Will they be identical or different?
Difference will be there, sir.
Okay.
Actually.
Why it will be different?
One uses mass high performance liquid chromatography.
Which one will show higher level?
Higher levels will be with I don't know, sir. High.
Yes, again, this is important to know, because practically also some labs will do LCMS, some will do immunoassay. Immunoassays usually will assay the metabolites also, right? Whereas LCMS will do only the TAC, so the level actually may be lower when you do LCMS. Can you tell us the common drugs which interact with tacrolimus? What is the interaction between TAC and MMF?
Actually, TAC causes MMF. Actually, they reduce the dose. Actually, MMF will cause reduced amount of. They compete for the.
What is the interaction? You give TAC and MMF, and let us say cyclosporin and MMF. Is there any difference? You can go and check. Okay, TAC and MMF. Any other interaction common?
Diltia, that non-dihydropyridines, then with azoles.
And what is the interaction?
Actually, they are enzyme inhibitors, so level will increase.
So you mean verapamil and diltiazem?
Yes, sir.
What about dihydropyridine?
Dihydropyridines doesn't have much significant compared to.
Much means it's not there, or it is?
It is there. Okay,
there. So what is the interaction?
It is actually it will enhance, inducer.
You can go and check that. What about other drugs, like say statins?
Statins actually, they will compete for P-glycoprotein mediated excretion, so there is increased chance for rhabdomyolysis and.
Interaction with the tacrolimus I am asking.
They will compete with each other.
So
level will be
TAC level will be higher.
Higher.
Okay. Any other interaction? Commonly used drugs.
Then
ranitidine,
Yes, sir. They ran it in. Then
any antiplatelet agent which has interaction?
Pyramidol.
That we don't use, no? Cardiologists are increasingly using some drug which has some interaction. What is the drug? Not clopidogrel.
Clopidogrel has a apixaban.
What is the interaction with the ticagrelor?
Yes.
You have heard, no?
Yes, sir.
Your cardiologists are using, right?
Yes.
Left and right.
Yes.
What is the interaction?
It's a CYP3A4 CYP3A4.
Inducer or inhibitor?
It's an inducer, sir.
Inhibitor. TAC level goes up. Right. Alright, you can go and read. Okay, very, very basic, important stuff.
So we have 2 more minutes.
So this is, you said about the post-transplant infections, that is that's CMV. All this, you know, when you go for another transplant, so the screening has to be what all things you will do a screen for the.
Sir, CMV we should screen before, because he may be on immunosuppressions even though in low dose. So we should screen for CMV, then BKV and all. Sir, then tortinovir, it's nothing. CMV, BKV, EBV we should look, actually EBV. Then sir, infections in the sense we should.
No, any
hepatitis B, C. Core
right.
positivity is there.
Right.
And then
no, because as you, the number of transplant goes up, the more chance of
increased tuberculosis we should look.
Okay. The one. Okay. Then what is the virus that causes post-transplant anemia?
Parvovirus.
Parvovirus.
B19.
What is the treatment?
Actually, parvovirus, IVIG can be given, then reduction in dose of immunosuppression, IVIG, then parvovirus.
Okay. BK virus, what is the standard of treatment?
Reduction of immunosuppression. First, we will reduce immunosuppression and we will look for MM of anti-metabolite will be reduced by 50%. We will wait for 4 weeks, then we will look BKV. If there is log 3 reduction, it's okay. If it is less than that, we should further reduce and stop antimetabolites. And if further it is not improving, we can reduce CNIs by 25%. And other thing is that if there is concomitant rejection with all, first we will treat rejection. And another thing is that we can give IVIG also for BKV.
Okay.
It has an immunomodulatory effect and reduces.
Immunomodulatory effect and fine. Okay, you have done well. That's presentation was very good. And you expect almost 90% of the questions that you have answered. You know, certain things, you know, on a decision, that's all. When it comes to, there could be difference of opinion between the consultants. That is the only difference that you and we people had. So you have done well.
Thanks.
You have done well.
Thank you, sir, and Dr. George Kurian, sir, for that insightful and engaging discussion. Now I would like to invite Dr. Jacob George, sir. Sir is a retired head of the department and professor of Government Medical College, Trivandrum. Presently, he is a consultant nephrologist at Cosmopolitan Hospital, SUT Hospital, PRS Hospital, and SK Hospital. Sir, I would like to invite sir for honoring the chairpersons. the chairpersons to give a token of appreciation to Dr. Manoj. Manoj is a senior resident from Government Medical College, Trivandrum. Jacob sir, one more photo. I will request the chairpersons to give a token of appreciation to Dr. Manoj. Now we will be having a final photo session. Thank you, sir.